lectures.
Good morning, my dear students. Good morning, all of you. Today, we'll be going through an important pulmonary disease, lung cancer, otherwise known as bronchogenic carcinoma. In the last class, we were discussing about the two airway diseases, bronchial asthma and COPD. Among these two, the COPD or chronic obstructive pulmonary disease occurs as a result of smoking habit. Likewise, most of the cases of lung cancer also occurs because of this dreaded habit of smoking. Now I'll go through the general overview of the lung physiology, followed by different types and classifications of lung cancers, the various causes and risk factors which leads to lung cancers, the different signs and symptoms of that, and how to explore, how to assess, and how to attain the diagnostic information of the lung cancer and different staging systems and the treatment and side effects of the treatment. So, breathing is the most important activity for a human being, and in this, lung, it attains the main prime role in breathing. The lower respiratory tract, it starts at the C6 level, at the level of the cricoid cartilage, wherein the trachea starts. The trachea starts from the level of C6 vertebra, cricoid cartilage, and it descends down till the landmark of T5 vertebra, where it divides into two main bronchi. This point of division is known as carena, C-A-R-A-N-A. Remember this. At carena, the trachea divides into two prime major bronchi, the left main bronchus and the right main bronchus. These bronchi divides multiple times into thin, slender, narrow airways, and these airways are known as bronchioles. And finally, these bronchioles end up as alveoli, where the gaseous exchange occurs. The required amount of oxygen will be taken up by your pulmonary capillaries, and the unwanted amount of carbon dioxide will be exhaled out of the capillaries into the alveoli. So this is the main action of the lung. Here, this is an autopsy picture of a healthy lung tissue. Here we can find a thin, slender line which is positioned between the posterior aspect of the lung from some intervertebral disc space. It is going laterally and it is ending anteriorly. This line is slitting the lung into two halves. It's a big fissure. What is that fissure? Is it major fissure or minor fissure? Yes, that is the major fissure, which divides the left lung into left upper lobe and the left lower lobe. And this is the lung which is devastated, which is fibrosed, which is necrotized, where there are many areas of ischemia, areas of calcification, areas of fatty deposits are present in this necrotic lung tissue. This is what happens when the lungs are affected by bronchogenic carcinoma. Going into the subject proper, the lung cancer, it happens to be the most common malignant tumor worldwide. And if you take in only UK, it is the third most common cause of death after the first position, the congestive heart disease, and the second position, cerebrovascular accidents. The third position is occupied by lung cancer. And among all the cancers which are leading to death, lung cancer occupies the most common cause of death due to cancer. So cancer-related deaths, in them, the lung cancer occupies the first position. It is very agonizing. It's agonizing to even know that the smoking habit is increasing in women, whereas in men, the smoking habit attained a plateau. There are no ups and downs in the male smoking habit. At present, the male to female ratio of the smoking rates is ranging between 1.2:1. Cigarette smoking is the prime main cause that accounts for more than 90% of the cases of lung cancer. So cigarette smoking is the main cause of lung cancer. It might not be only persons who are actively smoking. Yes, active smoking is the prime cause of lung cancer. Not only that, the persons who are passively smoking, who are passively being exposed to smoking habit, they also can attain the lung cancer. This is very pathetic. Apart from the smoking, the other etiologies that can lead to lung cancers are environmental exposure to radon gas. When you are chronically exposed to radon gas, that can lead to bronchogenic carcinoma. Exposure to asbestos sheets, asbestos dust can lead to lung cancer. Polycyclic aromatic hydrocarbons, ionizing radiations, and occupation exposure to arsenic, chromium, nickel, and petroleum and oil products. All these can lead to lung cancer. The host factors, like if there is any pre-existing lung fibrosis, the patient might be having a history of tuberculosis, pulmonary tuberculosis, or there might be silicosis, where the lungs might be fibrosed. As a result of this fibrosis, chronically, some patients can get bronchogenic carcinoma. And if the immunity is suppressed as a result of the HIV infection or because of some genetic factors, they can attain lung cancer. Coming to the main types of lung cancer, there are two. One, small cell lung cancer. Other one is non-small cell lung cancer. Small cell and non-small cell. Small cell happens to be around 20% of all lung cancers, and non-small cell carcinoma is the most common type of lung cancer, which it happens to be around 80% of the total cases of lung cancers. Coming to the small cell lung cancer, this is a very aggressive type of tumor. It is a very aggressive type of tumor which spreads early. The incidence, as I have discussed, it forms around 20% of the total lung cancers. These cancer cells arise from the neuroendocrine cells, APUD cells, aminopeptide uptake decarboxylation cells, and these cells secrete the polypeptide hormones. These hormones are responsible for the paraneoplastic syndromes. We'll discuss about this later. Paraneoplastic syndromes occur in 10% of the cases of only small cell lung cancer. Most of the cases of small cell carcinoma, they occur centrally. They arise centrally adjacent to the mediastinum in the lung, and the metastases are spread early to different organs. This chest X-ray shows that patient is having a paramediastinal mass in the right lung. There are many chances to misdiagnose this case as only consolidation or pneumonia, because there is airspace opacity here, and in that you can see the air bronchograms. Thin dark lines are bronchi, patent bronchi. If the air bronchograms are present in airspace opacity, then the chances of consolidation is the first prime diagnosis. So with this misdiagnosis, the patient as well as the clinician will be losing valuable time. So you should be cautious in getting the proper history from that patient. Coming to the non-small cell lung cancer, there are 3 types of them. One, squamous cell carcinoma. This is the most common type of lung cancer. So among the lung cancer, the most common type is squamous cell carcinoma. They form 35% of the total lung cancers. Subsequent to that, the second position is occupied by adenocarcinoma. The adenocarcinoma incidence is increasing at present. And following that, there is large cell carcinoma. These 3 form the non-small cell lung cancers. Coming to the squamous cell carcinoma, they make up around 30 to 40% of the total lung cancers. On presentation, these cancers will be moderately to poorly differentiated. They are more common in males, and they are also more common in smokers. They occur centrally in the large bronchi, similar to your small cell carcinoma. Both of these tumors, small cell as well as squamous cell, they originate centrally. They are very uncommon to metastasize early because these squamous cell carcinomas are slow in their growth and their spread to other organs like liver, adrenals, and lymph nodes is very meager. These tumors most commonly present as Pankos tumor. Most likely, these tumors also present as Pankos tumor. Here in this X-ray, we are viewing one space occupying lesion, some mass lesion which is occupying the right upper lobe. You remember this X-ray. We'll discuss about this Pankos tumor later. About adenocarcinoma, as I told you, its incidence is very increasing. And here, these tumors arise peripherally. Here in this X-ray, we can view a small space-occupying lesion in the right lower lobe. This right lower lobe lesion has to be evaluated, and it was found to be adenocarcinoma. Under the microscope, there will be glandular appearance of this carcinomatous tissue. It's easily seen on the chest X-ray, and it occurs in non-smokers, but the metastatic rate is very high in these adenocarcinomatous patients where the tumor spreads early to distant organs like brain, liver, adrenals, and bone. The other carcinoma is large cell carcinoma. They makes up around 15 to 20% of all lung cancers. Here, the cells are poorly differentiated, like your adenocarcinoma. This tumor also usually or commonly occurs in the outer part or the peripheral parts of the lung, invading the subsegmental bronchi as well as the larger bronchi. They are slow in their metastasis. So we'll go through a quick recap. I want you to remember what's the most common type of lung cancer, squamous cell. And among all the cancer, which is the most aggressive type of cancer, small cell, and which are the carcinomas which originate centrally, squamous, as well as small cell, and which are the carcinomas which occur peripherally, adeno and large cell. And you also know which are the carcinomas which metastasize or spreads early. That's a question to you. I want you to answer at the end of the class. Which are the carcinomas which metastasize or spread early, and which are the carcinomas which spread slow, which are slow in their growth and which spreads very late. So here we can see on the X-ray a centrally positioned mass lesion. The edges of the mass lesion you have to carefully observe the spike-lated, lobulated edges. Here, this is space-occupying lesion in the periphery's right lower lobe. About the etiology or the causes of lung cancer and the risk factors of that. As we have again and again discussed, cigarette smoking is the prime cause of lung cancer. Smoking not only harms the person who is actually involved in the smoking, but smoking also harms the person who is passively smoking. This lady is seated adjacent to a person who is puffing out his smoke, and the smoke is entering the patient, the female's lungs, and this can cause bronchogenic carcinoma if this happens regularly on a long term. Here, there is an asbestos sheets. When the person is exposed on a long term to asbestos dust from the asbestos sheets, with the person working in some factories where asbestos sheets are being prepared, patient can attain lung cancer. Exposure to arsenic dust and radon gas can lead to lung cancer. Coming to the types of lung cancer. it might be localized, that is, the lung cancer is only involving the lung, or the effects might be generalized, that is, the cancer has spread to other areas throughout the body, and it's involving the adjacent areas. Coming to the signs and symptoms, because of the localized action of the cancer, most common symptom is cough. Most of the patients who are suffering with lung cancer, they come with the presenting complaint as cough. Not only cancer, many of the pulmonary diseases, most of them, the most common symptom is cough. So in many countries, a 3-week cough algorithm is being followed. In that, when a person is having cough, in spite of taking medicines to curtail the cough for a minimum period of 3 weeks, then the patient has to be evaluated carefully by getting minimum a chest X-ray. Second one is shortness of breath. Shortness of breath, if the tumor is occupying the central position of the chest of the lung, and if it's causing lobar or lung collapse, that leads to dyspnea or shortness of breath. Not only that, you have to remember that most of the cases of lung cancer attain in smokers. Smokers' lungs are already very weak because of the presence of COPD. COPD causes dyspnea. It's the most common cause of dyspnea. Hemoptysis. Patient might be expecting fresh blood, bright blood, or patient might be expecting old or dark blood in his sputum. Recurrent lung infections might be present, and the hoarseness of voice is a feature when the tumor, which is positioned in the mediastinum, is pressing upon the recurrent laryngeal nerve. The recurrent laryngeal nerve is longer on the left side. So when the tumor is pressing on the recurrent laryngeal nerve of the left side, that leads to hoarseness of voice. Chest pain. Chest pain occurs if there is invasion of the pelvic parts of the thorax, like chest wall or pleura. This leads to sharp, stabbing, pleuritic, localized chest pain. And if the tumor is involving the mediastinum with a large volume mediastinal node, that leads to a dull central chest pain. A Fancos tumor. I was telling you initially when we were discussing about the squamous cell carcinoma, there is a mass lesion in the right upper lobe. This mass lesion, the apical tumor, otherwise known as superior sulcus tumor, These tumors invade the brachial plexus and cause the C8 and T1 palsy, wherein there will be shoulder pain, deep pain and numbness in the ulnar border of the upper arm, forearm, and ulnar border of the palm. All these will be affected by the Fancos syndrome. Horner syndrome, if the tumor is positioned centrally and the mediastinum is affected and the sympathetic chain is compressed by the tumor, that leads to ipsilateral ptosis. There will be drooping of the upper eyelid on the same side. Meiosis, there will be pupillary constriction of the eye on the same side. Anhidrosis, that eye will be dry eye, and there will be loss of ciliary reflex on that eye. Pleural effusion. If pleural effusion is present, it will be T4 carcinoma. There can be fatigue, and if there is any tumor in the trachea, that leads to inspiratory stridor. Superior vena cava obstruction. If the tumor is occupying the upper mediastinum, the mediastinum, as you already studied in your anatomy, is divided into upper mediastinum and lower mediastinum. Lower mediastinum is again divided into anterior, middle, and posterior mediastinum. So, in the upper mediastinum, if there is any mass lesion which is obstructing or compressing the superior vena cava, leading to superior vena cava obstruction, there can be dyspnea, dysphagia, stridor, dyspnea or shortness of breath because of the compression on the bronchi, dysphagia or difficulty in swallowing is because of the compression on the esophagus. Stridor happens when there is compression on the trachea. In these patients, the face and the upper arms will be swollen and edematous. There will be venous condition which is visualized in the neck. Dilated veins are present in the upper arms and chest. There can be invasion of the phrenic nerve. When the phrenic nerve is invaded, there will be paralysis of the ipsilateral diaphragm. Diaphragmatic palsy will be present on the ipsilateral side. Coming to the generalized signs and symptoms, patient might be having bone pain, headaches, changes in the mental status and neurological changes. There can be abdominal pain and elevation in the LFT, liver function test will be elevated. There might be enlarged liver. Whenever there is enlarged liver or hepatomegaly, we have to rule out any involvement, any secondaries in the liver. Gastrointestinal disturbances like anorexia and cachexia has to be ruled out, and jaundice has to be evaluated. Weight loss might be present. The extrapulmonary manifestations of bronchogenic carcinoma, if they are present, there can be non-metastatic. It's not due to metastatic spread of the carcinoma, but these are the extrapulmonary manifestations. They are the metabolic changes like loss of weight, loss of appetite, or anorexia, and lassitude or fatigue. Endocrine changes like ectopic adenocorticotropic syndrome, where the ACTH hormone will be produced excessively, syndrome of inappropriate secretion of ADH hormone, SADH, and neurological changes like encephalopathies, myopathies, and neuropathies, and vascular and hematological disturbances like disseminated intravascular coagulation, hemolytic anemia, thrombophlebitic migrants can occur. Skeletal changes like clubbing, grade 3 and grade 4 clubbing are very common in the patients suffering with carcinoma lung. Cutaneous manifestations like dermatomyositis can occur. When the tumor has spread metastatically, then the tumor usually spreads commonly to the mediastinal and cervical lymph nodes, which are affected early. The axillary and intra-abdominal lymph nodes can also be affected, but they are affected lately. If the liver metastasis is present, that leads to anorexia, nausea, and weight loss. Bone spread leads to pain and presence of pathological fractures, spinal cord compression. If this is present, the patient requires to undergo an urgent or immediate surgery. Adrenal glands, which are commonly affected by the cancer, but still they remain asymptomatic. Brain, if the secondaries are present in the brain, that leads to space-occupying lesion in the brain, which causes a mass effect. Due to this mass effect, there will be rise in the intracranial pressure, and the patient might suffer from seizures, headache, and loss of consciousness. Malignant pleural effusion can lead to shortness of breath and pleuritic stabbing chest pain on the same side. We have discussed earlier that when we are discussing small cell carcinoma, that around 10% of these cases who are suffering with small cell carcinoma can suffer from paraneoplastic syndrome. This is produced by the ectopic hormones which are secreted by these tumors excessively. This paraneoplastic syndrome, neurologically, they cause the Eaton-Lambert syndrome or the Lambert-Eaton syndrome, where the lower half of the body there will be paraplegia, paresthesia, and peripheral sensory neuropathy and cerebellar degeneration. If the endocrines are affected, that leads to SADH, syndrome of inappropriate antidiuretic hormone secretion, and ectopic ACTH hormone secretion. If the musculoskeletal system is affected, there will be clubbing and HPOA. What do you mean by HPOA? Grade 4 clubbing. Expand HPOA. Hypertrophic pulmonary osteoarthropathy. What are the features of that? Grade 4 clubbing. You give your answers. Skin manifestation are dermatomyositis and polymyositis. Coming to the staging of cancer, initially the clinician might stage the cancer based on the findings he gathers from the patient. And this is used to plan the initial therapy. Later, this has to be modified when the additional information is obtained after the pathological examination. Pathological staging is based on the examination of tissue samples which are obtained from the primary tumor, the tissue samples which are obtained after the biopsy of the lymph nodes and metastasis. This is helpful in planning the additional therapy and in follow-up. Cancer staging system. The TMN system is the most common staging system followed worldwide. It is developed by International Union Against Cancer. It guides the best course of treatment. It estimates the prognosis accurately, and if you are staging non-small cell carcinoma, then if surgery is seriously considered, TMN classification is vital. What do you mean by TMN? T stands for tumor, where the tumor size is monitored. N stands for node, nodal involvement, where the size and type of the node will be assessed. M stands for metastasis, where the general involvement in other organs and other tissues will be evaluated. In the tumor, there will be TX, tumor indeterminate, T0, no carcinomatous lesion, visualized T in situ, TIST, tumor in situ, and T1 to T4. In nodal, it ranges from N0 to N3, and metastatic, it ranges from M0 to M1. About the TMN classification, in the T1, the tumor size will be less than 3 centimeters. In T2, the tumor size will be more than 3 centimeters. And if the tumor involves the chest wall, then that is T3 region. And if the mediastinum is affected by the tumor, that is tumor T4 stage. And in the M1, the hilar and bronchial lymph nodes are affected on the ipsilateral side. If the ipsilateral mediastinal and even the subcarinal lymph node, if they are affected, they come under N2. And N3, when the contralateral, it's not ipsilateral, it's on the other side, opposite side, contralateral, mediastinal, and hilar lymph nodes are affected. M0, there is no known distant metastasis, and M1, distant metastasis is present. Here we have to know that till date, only 15% of the lung cancers are detected in the early stage when the tumor is still localized, when the treatment can be curative. About the diagnostic test, it can be chest X-ray, CT scan, MRI, sputum cytology, fiber optic bronchoscopy, and transthoracic fine needle aspiration cytology. About the CT scan, it indicates the extent of the disease. When you are doing the CT scan to evaluate the patient with suspected malignancy lung, then you have to also image the liver and adrenals, because liver and adrenals are the most common sites for metastasis. And the size of the mediastinal lymph node, if it is less than 1 centimeter, these lymph nodes are termed that they are not enlarged. Not enlarged doesn't mean that the lymph nodes are sterile, doesn't have any malignant cell. The patient, the lymph node can still be having malignant cells. It has to be evaluated by getting a biopsy. PET-CT scan, positron emission tomography. This is the investigation of choice in a patient who is suspicious to have malignancy. It confirms the mediastinal node involvement, and also it confirms the distant areas of metastasis. If the PET-CT scan report is revealed as negative, then its predictive value is quite high. That is, the patient might take it for granted to a large extent that patient is not having carcinoma. But if the PET-CT scan report is revealed to be positive, it needs further confirmation by getting a biopsy from the suspected site. About the laboratory tests, blood tests, complete blood counts. This is used to check the red and white blood cells as well as platelets. The bone marrow and the organ function will also be checked by getting a peripheral smear. Blood chemistry is used to know how the other organs are functioning, especially the liver function test and the renal function test. Biopsy is required to determine if the tumor is cancerous or is it not. The biopsy is used to determine the type of the cancer and the grade of the cancer. Here, a patient is undergoing fiber-optic bronchoscopy, which is utilized to view the patient's airways, and if there are any abnormalities, the biopsy can be taken from that suspicious site using fiber-optic bronchoscopy. Three types of endoscopies are very vital in investigation of lung cancer. One, bronchoscopy. Second, mediastinoscopy. Third one, thoracoscopic, video assisted. About the bronchoscopy, a narrow lumen flexible tube will be passed through the patient's trachea. Here, in this case, bronchoscopy is passed through the trachea. It's entering the right lung, and here there is an orange lesion suspicious to be malignancy. So from this side, the biopsy will be taken to get the diagnosis of that etiology. In this case, mediastinoscopy is being done, an incision is given in the neck, and the mediastinoscope is passed into the mediastinum, and the biopsy will be taken from the suspected lymph node. Here, a patient is undergoing thoracoscopy, video assisted. If you suspect a lesion, a tumor in the pleura, if there is any pleural thickening, then we can get a pleural biopsy, and if the pleural cavity is filled with pleural fluid, the fluid can be drained and the pleura can be adhered. Pleurodiscs, that is, the pleura can be made adherent to each other. Pleurodiscs can be done by using thoracoscopy. So, three types of endoscopies: during the procedure and after the procedure. Patient vital signs have to be carefully monitored. Patient should be made to remain nil per oral status till his gag reflex returns, and there are potential for infection, dyspnea, and bleeding in most of these cases, and you should be cautious of this. Three types of main cancer treatments are available. One is surgery, radiation therapy, and chemotherapy. About the surgery, removal of the tumor is only useful in the stages, stage 1 and 2 of carcinoma lung. If the patient enters into stage 3A, a few cases are selected wherein the surgery can be done, but in rest of the cases, say 3B and 4, surgery is not at all an option. Only radiotherapy and chemotherapy is the curative, is the treatment available for stages, stage 3B and stage 4. In the initial stages, surgery is an option. 1 and 2, that has to be remembered. The other treatment aspects which are available are hormonal therapy, biological therapy, and stem cell transplant. There are many side effects based on these treatments. Surgery, there might be hematomas, hemorrhage, pain, altered respiratory function, and there can be risk of having collapse, pneumonia, and hypoxia. In the radiation, there will be nutritional intake will be decreased, and hematopoietic function might be low. In the chemotherapy, patient might be having anemia and thrombocytopenia, as well as fatigue, alopecia, dizziness. In radiotherapy, lately, this treatment maneuver entered into this treatment maneuvers. These are laser therapy or endobronchial irradiation. These therapies can be utilized in patients who are in stage 1 and stage 2 cancer even. These are Nd:YAG laser, where in neodymium, YAG laser is used, and brachytherapy, where the endobronchial irradiation is utilized, and tracheobronchial stents might be placed in the tumor area, wherein the tumor can be made to dissolve. All these therapies are now being utilized in patients who are in stage 1 and stage 2. And lung resection, which is the only curative treatment which is available for the treatment of lung cancers, but this is only restricted to patients who are present in stage 1 and stage 2, along with few cases of stage 3A. Different types of lung resections are lobectomy. A single lobe of the lung is removed. Myelobectomy, 2 lobes are removed. Pneumonectomy, the entire lung is removed. There can be sleeve resection, segmentectomy, wedge resection, etc. About the prognostic factors of lung cancers, this usually is based on how the patient will do because of the type of cancer cells, grade of the cancer, location of the cancer, size of it, staging of the cancer at the time of the diagnosis of the tumor, the age and gender of the patient, and the results of different blood and other tests, and how is the patient responding to the treatment. About the secondary prevention, is used to screen lung cancer in some countries. It's used to detect or diagnose the lung cancer early in patients who are high-risk population. For this, the chest X-ray, MRI, CT scans, and sputum cytology is being utilized. The tertiary prevention is targeted on patients who already survived a cancer disease, and this tertiary prevention assists them to retain an optimal level of functioning regardless of that potentially debilitating disease. Thank you. Here, I want all of you to remember the horrifying, life-threatening impact the smoking of a cigarette can have in our lives. So never get yourself affected by smoking. Never never be a prey to the smoking habit. And if you recognize that any of your close friends or relatives are smoking, try to make them abstain from smoking, make them stop smoking. That gives a lot of confidence and energy because of the good habit of not smoking. Thank you. Any questions? I'm waiting for your questions. If there are no questions, we'll meet again. I want you all to go through your textbooks and revise this topic, lung cancer. When you revise this early, all the points that your grasp will be strengthened in your minds and will be very useful for you. Bye. I agree.